Hi, my name is Victoria Chen, and today I'm going to talk to you about anemia among refugees. The reason I chose the topic of anemia was because I have it, but I really know nothing about it other than the symptoms. Also, two of my children are carriers of the sickle cell trait. I chose to discuss anemia specifically among the refugee population when I was doing a project for another class about issues refugees face. Anemia is one of them. So what is anemia? Anemia is when blood does not carry enough oxygen to the rest of the body. The three main causes are, number 1, blood loss, number 2, lack of red blood cell production, and number 3, high rates of red blood cell destruction. In the picture to the right, we see a person with a normal amount of red blood cells who is not anemic, and then another picture of an anemic person and the amount of red blood cells that he or she has. Anemia is diagnosed with a physical exam and a blood test. Some symptoms of anemia may include fatigue, irritability, shortness of breath, headaches. A person may feel cold, dizzy, have pale skin or chest pain, and there's a few other ones that you guys can read. I know for myself personally, I have low blood pressure, which sometimes has led to dizziness and fainting, which is really embarrassing. I get tired and cold, and I also have headaches. The global prevalence of anemia for the general population is 24.8%. The highest prevalence is found in Africa, followed by Asia, the Eastern Mediterranean, the Western Pacific region, the European region, and the Americas. The prevalence of anemia among refugees is not exactly known. That's because the state refugee health coordinators did not conduct surveys annually. But from 2004 to 2010, the anemia prevalence in refugee camps was greater than 40%. Refugees are generally at high risk for anemia due to displacement and food insecurity. Most refugees that come to the U.S. are from the continents of Africa and Asia, where the highest prevalence of global anemia is found. The definition of a refugee is an individual who, owing to a well-founded fear of being persecuted for reasons of race, religion, nationality, membership of a particular social group or political opinion, is outside the country of his nationality and is unable to, or owing to such fear, is unwilling to avail himself of the protection of that country. Now I'm going to speak to you about a few of the determinants of anemia. The first one is iron deficiency. This is the most common cause of anemia and is what normally is associated with the term. The body needs iron to make hemoglobin, which is what carries oxygen from the lungs to the rest of the body. As you will see during this presentation, iron deficiency is not always the cause of anemia. While iron deficiency is considered to be the most common cause, other nutrient deficiencies and diseases may also contribute. In the 2010 Global Burden of Disease report, iron deficiency anemia was ranked as the third leading cause of disability globally. A study done among refugee children entering DeKalb County, Georgia, showed refugee adolescents had a prevalence of iron deficiency anemia 2.5 times higher than their U.S. counterparts. Refugee children under 5 years of age had a prevalence of iron deficiency anemia 1.5 to 5 times higher than their U.S. counterparts. Diets are also a determinant of anemia. Research has shown in the Eastern Mediterranean region there is a high prevalence of iron deficiency anemia due to a low intake of foods containing ferrous iron. These people also consume breads with non-fermented dough and certain spices such as thyme, which may block iron absorption. A study done on rats found different types of thymes used in foods or teas led to the development of anemia caused by insufficient iron and vitamin B intake. The rats were administered tea with various types of thymes. In doses under 80 milligrams, which is about a teaspoon, the rats did not become anemic. A dose of 160 milligrams, however, did cause anemia. A study done on people in Africa also noted that they have a high intake of plant protein as opposed to animal protein, which may also lead to a lower intake of dietary iron. The high amount of grains they eat also tend to absorb the iron. These are the diets of many refugees. Socioeconomic status may also lead to iron deficiency anemia. Research from the Korea National Health and Nutrition Examination Survey showed girls with higher income had lower anemia prevalence. It also showed anemia tends to decrease as household income increases. One of the reasons may be people with a higher socioeconomic status consume more iron and are able to afford vitamins. Food insecurity may also be a factor. 4 studies conducted in the U.S. have linked anemia among infants, children, and adolescents to food insecurity. One of the leading causes is diet, since evidence suggests food insecurity can result in low food and nutrient intake. Diets in food-insecure households tend to be lower in iron and other nutrients and higher in carbohydrates and fats. A study done on African women showed their mean daily intake of calories to be only 1,434. According to WHO guidelines, a non-pregnant woman weighing about 130 pounds with a low level of activity should consume at least 1,984 calories a day. Refugees generally have low socioeconomic status and high food insecurity. Pregnancy may also be a cause of iron deficiency anemia. It is a global problem, but especially high in developing countries, which is where refugees come from. In these countries, it may occur in up to 61% of pregnant women. Inherited conditions are also a factor. A little disclaimer before I begin, I have no idea if I am pronouncing these disorders correctly. Hereditary diseases such as hemorrhagic telangiectasia, thalassemias, folate malabsorption, G6PD disorder, and sickle cell anemia may also cause anemia. Hemorrhagic telangiectasia is a chromosomal disorder which causes frequent nosebleeds, which may be difficult to control. The blood loss may be chronic, which results in iron deficiency anemia. Thalassemias are a group of disorders where a decrease in either the alpha or beta globin chain decreases the production of red blood cells. Hereditary folate malabsorption is a rare chromosomal disorder which results in folate deficiency. When left untreated, it may cause megaloblastic anemia. G6PD deficiency is a genetic disorder most common in males. It affects the red blood cells and can cause hemolytic anemia. Sickle cell anemia is another genetic disorder. People with sickle cell anemia are born with 2 sickle cell genes, one from each parent. The cells are shaped like a sickle instead of being round. They don't last as long as normal blood cells. This leads to anemia. According to the CDC, inherited hematologic disorders are common among refugee populations. These disorders are most common in places with a high prevalence of malaria because some of these disorders provide a defense against the disease. Certain diseases may also cause anemia. Malaria is one of those. It's most commonly carried by a mosquito. It leads to anemia by causing impaired intestinal iron absorption and impaired iron release from hepatocytes, which leads to iron deficiency anemia. In a study done among pediatric patients, children between 13 and 36 months were most at risk due to poor immunity of the disease. Schistosomiasis is another disease which can cause anemia. It is carried by a parasite found inside a certain type of freshwater snail. The anemia in schistosomiasis can come from 4 different conditions: an iron deficiency due to blood loss, the spleen not working correctly, the autoimmune response to the breaking down of the red blood cells, and inflammatory anemia. These are both parasitic diseases which occur mainly in poor tropical and subtropical areas of the world where many refugees come from. Poor sanitation increases the risks of contracting the diseases. The highest prevalence of these diseases are found in Africa. HIV can also cause anemia. Anemia is the most common blood disease found in HIV patients. It has been documented that up to 95% of HIV patients are anemic. The most common anemias encountered are iron deficiency anemia and anemia of inflammation. A study done on HIV-infected people between 25 and 60 years of age attending the Federal Medical Center in Nigeria found the patients not to be iron deficient, but to have anemia of inflammation. A study done among children with HIV between the ages of 6 months to 3 years showed 79% had anemia, and in these instances, the anemia was found to be mainly due to iron deficiency. Most of the refugee population who have HIV is due to unprotected heterosexual sex. There's an idea that in conflict-affected populations, there's more sexual risk-taking behaviors, which would place refugees at an increased risk of acquiring the disease. Lead in the blood may also be tied to iron deficiency anemia. This is because the lead interferes with the normal formation of hemoglobin. Studies have shown absorption of lead tends to increase in children who have low iron diets. In a study conducted, researchers found the blood lead concentrations to be significantly higher in children with iron deficiency anemia. Lead was tested in both blood and hair. Other studies have found infants with iron deficiency anemia have a significantly higher blood lead concentration than infants without anemia. According to WHO, the highest blood lead levels are found in low-income countries, especially those that have mines or countries who still use leaded gasoline. Leaded gasoline is still used in some countries in the Middle East and may therefore affect the refugees from that area. This is my web of causation conceptual model, which shows how all these determinants are linked to anemia as well as to each other. For example, your socioeconomic status can affect both the environment that you live in as well as food insecurity. The environment that you live in may have lead in it. It also may lead to parasitic diseases in certain areas, and the parasitic diseases may lead to inherited conditions such as sickle cell anemia, and another inherited condition could be HIV. As far as the food insecurity, that causes a diet which may be low in iron, which may lead to iron deficiency, and during pregnancy, iron deficiency may also occur. As far as social work perspectives, social workers who work with refugee populations generally assist in other capacities. The health workers are the ones who deal with the anemia. However, there have been studies regarding the behavioral effects and social-emotional differences of children with iron deficiency anemia. Infants with iron deficiency anemia have been observed to be more wary, hesitant, fearful, withdrawn, shy, unhappy, tense, less playful, and show less pleasure in reaction to stimuli. If the anemia is left untreated, these infants become young adolescents who show increases in anxiety, depression, social problems, and feelings of detachment. A study conducted with an iron-supplemented group and a no-added iron group of infants assessed 10 years later found more adaptive behavior among the children who were given iron. Therefore, according to this study, iron supplementation in infancy is associated with improved school performance, mental health, and personal relationships at age 10. Therefore, perhaps social workers should take these potential side effects of anemia into consideration when working either with refugees or other populations which may have IDA. For community-based responses, I found the Iron Like Turkey community-based program. This program works with infants 4 to 23 months. It includes free iron supplementation to all children under 1 year and provisional iron treatment for all 4 to 24-month-old children diagnosed with iron deficiency anemia. The goal is to prevent anemia and improve the nutritional status of infants. There are 5 major components: advocacy, support for effective training, support for effective counseling, a public education program, and free supplementation or iron medication to infants 4 to 12 months. The supplementation use in this project is 68.8%, and the prevalence of anemia is now down to 7.3%. Therefore, for now, the program seems to be achieving its goal. As far as health-related policies are concerned, a current and controversial policy is the mandatory NCAA sickle cell trait screening program. I have mixed feelings about this policy because, as I mentioned earlier, I have 2 children with the sickle cell trait and they both play sports. This policy resulted from a legal settlement when a football player collapsed and later died from acute exertional rhabdomyolysis, which is a complication of the sickle cell trait I never knew existed. This policy targets student athletes with sickle cell trait. The goals of the policy are to screen athletes for the trait so the necessary precautions can be taken. This policy has been tested. A policy analysis was conducted to estimate the number of athletes with the trait and the anticipated number of exercise-related deaths caused by the trait among NCAA student athletes. Here are the policy analysis results. It was estimated the policy would identify over 2,000 athletes with sickle cell trait among a 4-year cohort of student athletes. If the intervention proves to be 100% effective, screening could prevent the deaths of 7 student athletes over a 10-year period. There are costs associated with the testing, and there is also potential for discrimination towards athletes identified with the trait. Furthermore, even if the athlete and staff know the player has the trait, there is no guarantee they will comply with the guidelines. Some coaches just choose to ignore them. In order for this screening policy to be successful, the NCAA needs to have an intervention plan as well. When refugees come to the United States, they're permanent residents and able to attend schools and universities. If they become involved in athletics, this policy may affect them. So in conclusion, what have we learned? Well, we've learned that anemia is when blood does not carry oxygen to the rest of the body, which may be caused by several different factors. We've learned refugees have a greater chance of becoming anemic due to certain circumstances. We learned anemia may affect behavior, which has implications for social workers working with refugees or other anemic populations. We learned that community programs primarily target infants and pregnant women in hopes of preventing anemia. And we've learned that policies for certain forms of anemia may lead to discrimination of certain populations. These are my references. And this is the end of my presentation. I hope you enjoyed it.